Hello everybody, this is Dr. Christy Day with a few more study tips for exam 1, and this is part 2. Let's go ahead and start on the cardiovascular problems, including hypertension, hyperlipidemia, MI, heart failure, coronary heart disease, murmurs, and peripheral arterial disease. Of course, for each one of these, you're going to go through those same uh, areas of risk: clinical presentation, physical exam, screening and diagnostic tests, diagnostic criteria, and treatment plan. Hypertension is one of the most common chronic health problems. 95% are essential hypertension. Of course, you need to know the risk factors and then be able to differentiate between essential hypertension, secondary hypertension, white coat hypertension, and hypertensive emergencies or urgencies. For the classification of hypertension, you should be able to classify hypertension by normal blood pressure, elevated blood pressure, stage 1 hypertension, and stage 2 hypertension. And it's important for you to understand how to measure and to then diagnose hypertension from your measurements. And the assessment should include 2 blood pressure measurements in both arms. And the patient should be seated with feet flat on the floor, back supported, and with the arm at about heart level. Support the arm. The patient should be quiet, not speak, and in the appropriate size blood pressure cuff. Now, you all learned all this. You've been nurses for years, and you've probably taught people how to do blood pressure, and that's a lot of what you're going to be doing. And as a nurse practitioner, you may be teaching your medical assistants, you may be monitoring, make sure they're taking it right, and you also may be teaching the patient how to take their blood pressure. And it doesn't end just because you're a nurse practitioner. We still have these little details to worry about, because we don't want to have falsely elevated blood pressures and start people on medications when they shouldn't be. And an interesting thing is if you do have blood pressures are high in both arms, you can take it again after they've been standing for 2 minutes and then see which recordings are the highest. You can diagnose primary hypertension with a 24-hour blood pressure, at-home blood pressure monitor, or sequential home BP reading. So you're going to be teaching a patient to do these outpatient blood pressure readings, and this is to rule out white coat or masked hypertension, and to identify hypertension symptoms when the patient is being treated on antihypertensive medications. Malignant hypertension is a term that our textbook uses. I thought that was going by the wayside. And it also mentions hypertensive emergency and hypertensive urgency, which I've seen used more lately. It happens, these type of emergencies or urgencies happen about 1% of patients diagnosed with primary hypertension. Malignant hypertension is diagnosed when the patient presents with severely elevated blood pressures in the range of 180 over 110 or higher, and in the presence of acute target organ damage. That's the key. You may have a patient come into the clinic and have extremely elevated blood pressure, and the first thing you're going to do is to assess them for target organ damage, because that's the difference between an urgency and an emergency. A patient presenting with acute, severely elevated blood pressure requires a thorough examination: blood pressure, target organ damage. This evaluation should include fundoscopic, palpation of the chest, auscultation of the heart, abdominal assessment for bruits or widened aortic diameter, enlarged kidneys, examine the carotid arteries for bruits, palpate the peripheral arteries, a neurological examination, are there any mental status changes, EKG, urinalysis, serum creatinine, and a chemistry. You can always also order a chest x-ray. Now, what I do when I have a patient that I find with severely elevated blood pressure, the first thing I'm going to ask them is, do you have a headache? Do you have vision changes? Do you have any chest pain? Have you been producing urine? Do you have any edema? These are sort of the questions that I'll ask them before I jump in and start examining them. Because if there's any, if they're having chest pain and this elevated blood pressure, I'm not going to take time to go through all of these assessments. I'm going to go ahead and get them out of there, get them to the hospital to get some IV antihypertensive to bring their blood pressure down. Because and a hypertensive emergency is a crisis, and it could lead to death, stroke, all of the things. Renal, end stage renal, all the things that you can have when you have lack of blood flow to target organs, to important organs. Hypertensive emergency or hypertensive crisis are different. They're sometimes used interchangeably. And this is, like I said, they need immediate IV antihypertensive therapy in an acute setting. Hypertensive urgencies, those are people with severely elevated blood pressure, but no signs of target organ damage. They can be treated with oral agents over 24 to 48 hours to reduce their blood pressure and stabilize them. And so that we don't send everybody to the hospital that comes in with severely elevated blood pressure, even though we may want to. So you can see in the textbook there's a list of the type of symptoms that and cardiovascular events that a cardiovascular emergency can trigger. The Fitzgerald Amplify course assignment for hypertension is an excellent way to help you understand the hypertension management guidelines, as well as medications, mechanism of action, contraindications, and adverse effects. You will find medication used to treat hypertension appear on guidelines for other problems. Think of how the various antihypertensive may have a secondary effect on mood, anxiety, and benign prostatic hyperplasia. For the purpose of this test, and most likely for your boards, focus on the primary prevention and actually acute and chronic management of hypertension, versus going into a lot of the complicated cases where they're they've already had a cardiovascular event. I think, for the purpose of this exam, it'll make it a little easier for you to focus in. You also have a lecture available to you in Fitzgerald Amplify, which is a comprehensive explanation of lipid management. I highly recommend that you listen to this lecture a few times to help you understand the various decision points, such as the ASCVD risk calculation and comorbidities, and how those affect your decision making. These various calculators and comorbidities play a role in deciding whether to treat the dyslipidemia with medications. Of course, the first line treatment for dyslipidemia is statins. In the past, we monitored liver enzymes after starting the statin, and then periodically there was some, some people were doing it every 3 months, some 6 months, but routine labs are no longer recommended. And I will usually, if they start on a new drug, a statin, I'll go ahead and check their liver enzymes maybe at 6 and 8 weeks, just to make sure they're not having a reaction to it. And then the main reason to check labs after that is to check for medication compliance. Be sure and review the follow-up lab monitoring for people taking statins. And the main reason to check labs is to understand the medication effect. And what we know is that the high intensity, medium intensity, and low intensity statins all have predicted values of how much to expect a lowering of the LDL. So if it says that the LDL should go down 50%, you can pretty much bet that if somebody's taking the medication every day as instructed, their LDL will come down 50%. If you don't see that on the labs, you probably need to ask if they're missing doses or if they're tolerating the medication. This is the algorithm that helps you make decisions about starting a statin or treating hyperlipidemia. And this is the from the ACC-AHA, and this is the algorithm that you should be learning and following in practice. Most patients that you see who have a confirmed cardiovascular disease or event usually will be in specialty care. And also, you may find patients who have had coronary artery stents and other serious CV procedures who are not following up with their cardiologist. For this reason, it's important for you to understand the medications they're expected to be on for secondary and tertiary prevention. And then you would know, hey, why aren't they on an aspirin? Why aren't they on this? And so that's important for you to know. For coronary heart disease, in most patients, coronary heart disease develops many years. It starts the development many years before the patient even knows that it's happening. Typically, symptoms of coronary heart disease are not reported until about 3/4 or 75% of the coronary artery is narrowed due to the atherosclerosis. Now, if you think about it, they have coronary arteries coming down, and when these start to narrow a little bit, the body will naturally produce collateral circulation. They'll develop other blood vessels to provide oxygen to the heart. And this is a compensation for the narrowing of those main arteries. And so when you have a patient that comes in with complaining of chest pain, your differentials are going to be, musculoskeletal, GI, cardiac, pulmonary. There's just a number of problems that they could be having. So you'll want to make sure that you know your risk factors for coronary artery disease and evaluate your patient for that. And most often when they come in, the first sign of coronary heart disease is going to be stable angina. And it'll be chest pain or discomfort with activity, which resolves with rest, and that's a stable angina. If you have a patient with stable angina, the main thing to know is that they're to determine that it's actually stable. Did it go away? Do all your EKG and all that. The book mentions a major workup for coronary heart disease, and of course they need that. But in primary care, that's usually not the place that happens. You can, even drawing troponins is going to be difficult in a primary care setting. First of all, if you have a lab, they're probably not going to pick up specimens until later, that you're going to be resulted the next day. That would be too late. And you have to keep that in mind when you actually are in clinical practice and you have a patient that is suspicious for unstable angina or even, angina. So you can collect some labs and you can do an EKG. You might be able to do a chest x-ray where you're at, but it's pretty limited. And your role is going to be to determine if that's an emergency or not. acute coronary syndrome is a term used for the disorders of the myocardial ischemia, such as non-ST elevation MI, ST elevation MIs, and unstable angina. The definition of unstable angina is newly diagnosed angina or previously diagnosed angina that has changed in pattern, frequency, or severity. Unstable angina is commonly a forerunner of an acute MI, which we all know is necrosis of death of the myocardium tissue as a result of prolonged ischemia with insufficient supply of oxygenated blood. As far as outpatient management of an MI, an acute MI, your best approach is to diagnose the problem and treat them with first aid. First aid is you are the first person to see them and to understand what's going on. Give them aspirin, nitroglycerin, and oxygen if it's available. And be sure that someone calls 911 right away, before you start the treatment. When you know this is happening, get them out of the clinic. You don't want to, you don't want to delay them going to the hospital and getting the care that they need because you want to be sure. I want to make sure, I want to order troponin, I want to get all this. If you think about it, and a patient's in the clinic and you are in a rural clinic somewhere, you're not going to be able to get troponins and CKMBs and all that. And so you don't want to delay their care. But you'll need to know the most specific laboratory tests to rule out are the cardiac specific troponin 1s, the troponin 1 assays, and the CKMB. These are the labs that you'll see ordered. And you'll want to know the time frame. You won't see these in healthy people. They should not be detectable in healthy people. So troponin levels rise within the first 2 to 4 hours after an MI and remain elevated for 7 to 10 days. And they have, the high sensitivity cardiac troponin the results are sooner and all that. But I don't think you're going to be doing that in primary care unless you're, going to be working in the urgent care section of the ER or something like that. So as far as what you need to know to pass the boards and for your education and your entry-level nurse practitioner, you would at least be familiar with the troponin levels and the time frame that they would be high, and you would want to know how your patient will be treated post-hospitalization. You want to know what they're going to come back on, any platelet therapies, statins, and things like that. You may see EKG strips on your exam related to arrhythmias, so be sure to review the common EKG findings such as atrial fibrillation, premature atrial contractions, myocardial ischemia, normal sinus rhythm, tachycardia, bradycardia, and any other life-threatening arrhythmias. Just be able to identify them on a strip. I also recommend that you review, the clinical presentations of the heart dysrhythmias as described in your textbook. What would you expect a patient to be complaining about? Are they symptomatic? Do they have elevated heart rates? And know your primary care role. And a lot of the workup in the textbook takes it all the way through acute care. Know what the primary care role is. What can you actually do in the clinic, and be sure to focus on those sections. Supraventricular tachycardia. The initial treatment for stable SVT consists of vagal maneuvers, which will increase the parasympathetic tone and slow conduction through the AV node. These techniques include coughing, blowing into a pinched or sealed straw, lying on the floor while elevating one's legs against a wall, or squatting. If the clinician has experience with carotid sinus massage, that this maneuver is usually effective. I've never done that, and I haven't been taught how to do it, so I wouldn't. However, carotid massage is contraindicated with patients in coronary artery stenosis, bruits. Facial immersion in cold water is another vagal maneuver. Um, Never use eyeball pressure as a vagal maneuver, and because it can damage the eyes and be unpleasant for the patient. So kind of those are some tips for you with your studies. Heart murmurs are actually very easy to evaluate. They sound difficult, but if you break it down into the sections, how loud are they, where do you hear them, all those things, what stage in the heart cycle do you hear it, and if you just take it one step at a time and you just sit back and listen and evaluate, you will look so smart. I'm going to tell you, here's the secret. Just determine where the murmur is heard the loudest. Listen to the auscultation points on the chest and determine where it is heard the loudest. So the way that you'll know these points is to know the name of the points and where they are according to the anatomy. So the point at which the murmur is loudest indicates which valve is involved. There's your first clue. For example, if you heard loudest over the mitral listening point, then we have a mitral murmur. All right, that sounds good. In a patient with an undiagnosed heart murmur, you hear a murmur, what is going to be your first step in the diagnostic process? So now we know that the murmur is occurring in the mitral listening point, so it's a mitral murmur. Now listen and figure out whether it's during systole or diastole. Does it happen with the beat? Where do you hear it? Or after the beat, systole or diastole? Sometimes it's a little hard to figure out, especially with if a murmur just kind of blows away the whole cycle. You're just hearing this huge murmur. So you'll determine the point at which you hear it, and then you'll determine where in the cycle it occurs. If you can't figure it out, then place your fingers on the carotid pulse while you're listening, and then the carotid pulse is felt during systole. So if you hear the murmur, when you feel the pulse, that's a systolic murmur. And as a note for you to think about, diastolic murmurs are always serious problems. If you hear a diastolic murmur, then you need to pay attention. The next step, after you've determined where it's heard the loudest, where it is in the cycle, how loud is it? So you hear, grade 1, grade 2, and so now we have a systolic mitral murmur, and then we're going to add the grade. Can you hear it barely? Is it the lowest intensity? Is it, low intensity, but most people can hear it with their stethoscope? Is it easy to hear, even just for anybody that tries with a stethoscope, but you don't feel a thrill when you place your hand on their chest and then go through the stages? It's a stage 4 medium intensity with palpable thrill. And so you can go through those, and let me tell you, when you're doing your diagnosis and you're writing your notes, if you're able to say there is a murmur, a systolic murmur present, grade 2, half the battle is gone, because then you can go to the next step When you understand what you're listening to and you know that you have a systolic mitral murmur, then you can go to a simple chart and it gives you an idea of what the problem could be. And if you have a patient with an undiagnosed murmur, you're the very first one to hear it. These simple listening techniques and the way to describe it in medical terms will tell you what the next step is. And with most patients with a systolic murmur that's just being diagnosed, the next step is to do an echocardiogram. Peripheral artery disease is arteries carry blood to and oxygen to the extremities. And these are the arteries. So I know it sounds really simple, but once you start thinking of it as two different problems to do with the extremities, the arteries versus the veins, it really helps. Arteries carry blood and oxygen. When there's not enough oxygen, there can be pain like claudication and other problems of ischemia to the lower extremities. This one also has some really good board reviews that are on the shorter side on YouTube that will have pictures and diagrams and really help you to understand this problem with audiovisual lectures. When there's an occlusion of an artery going to the leg, that is considered an acute emergency. Acute episodes such as blood clots and trauma and other problems can lead to loss of limb. We're not talking about something that builds up over time. We're talking about something that's acute. For example, you have a clot that goes from somewhere else into the leg. They're throwing clots and goes into the leg. Think of the 3 Ps. I mean, I don't know if you've heard this before. I don't see it in your book, but this is how I learned it. If you have an arterial occlusion that's an acute problem with risk of loss of limb, you're going to have pain, pallor, and pulselessness. So it's going to hurt, it's going to be, the color is going to lose color, and you're not going to feel a pulse. And it's not usually accompanied by edema. And with the vascular problems, the vein problems, you're usually going to have edema because of the backflow and the pump problem. So for the evaluation and management of non-emergent peripheral arterial disease, you should review the risk, clinical presentation, examination findings, testing, management, referral, and education. A big part of what you're going to do with these type of things is do what you can, diagnose what you can, do the workup, and if it's indicated, refer them and teach them about the problem. Stop smoking. You should do all the things like statins, and if a anticoagulant or any platelet is indicated. So go ahead and read about all that, and it's something that you need to know for practice and for your boards. And on this slide, you'll see a little bit more about the specifics of the management of peripheral arterial disease. You can review that here and in your textbook. For deep vein thrombosis, this is something that you really do need to know because you will see this in primary care. You will diagnose this in primary care, and you will often treat it in primary care. Gone are the days when immediately when we had a DVT, they were sent to the hospital. That's not the case anymore. It depends on their symptoms, the severity. You can do a workup. And so this is clinical judgment. It has to do with where you're working, and also if you have a collaborating or delegating physician, their opinion on this. But in states where you do have a delegating physician, it's really important to share this information with them and to collaborate with them on a DVT to decide whether to admit them to the hospital or to manage it outpatient. And because this is going to be something that you're going to see in primary care, you want to understand the physiology, the pathophysiology, the risk factors, clinical presentation, physical exam findings, diagnostic testing, treatment, and referral. Chronic venous insufficiency is a disorder of the valves within the deep veins of the lower extremities. Valves within the veins assist venous blood flow up towards the heart to keep it from pooling in the legs. And they regulate the direction of the flow of the blood. So when the valves will prevent the blood from falling back down into say it's in the calf, from falling back down. The heart will pump, it'll go through the valve will close, and then on the next pump it opens again, and that's how the blood gets back to the heart. And in chronic venous insufficiency, these valves are essentially failing, so you get a lot of pooling of blood and edema in the legs. So first of all, understanding that the physiology and the pathophysiology is really important, and to understanding how we treat this. So you may see varicose veins, you may see venous stasis, you may see distension of the veins, thinning and scaling of the skin, dusky discoloration, dermatitis, and venous ulcers. You'll also see a lot of dependent edema and poor wound healing. And I'm sure you've all had this, seen this in your registered nurse career, and so it's important to know how you play a role with that in primary care. I hope you find this helpful for your studies, and don't hesitate to reach out if you have questions or concerns, and I will do my best to answer your questions. Take care.